welcome everybody to today's webinar on the topic of navigating transplant outcomes, what transplant centers need to know. My name is Heidi Aguiar, and I'm part of the Alliance team, and I look forward to passing on the baton shortly here to our moderator for today. We have a fantastic speaker lined up for you. But before we get started, a couple of housekeeping items. For those of you who've not been part of our webinars before, we are recording this webinar, so all the lines will remain muted. So for you to submit questions, you just need to click on that bottom left-hand corner icon and type in your message to us, and then we will hold any of the questions that you have till the end of the presentation, and then our moderator will moderate those questions. Also, just as a reminder, for those of you who might be listening via audio, via computer audio, please make sure to have the information that had the webinar link in it on hand that also has a phone number in it. So if you lose computer audio, you can dial in on the phone and you should be able to have audio. Sometimes folks who listen in on computers sometimes lose their audio. Also, just a couple days away, we have our next and our final innovation webinar for this year on the topic of can nanotechnology and vitrification change the face of organ transplantation. So registration is still open for that, and you just need to go to the organdonationalliance.org website under education. Also, we're going to be excited to share our 2018 webinar calendar very soon. But just to give you a little glimpse, coming up, registration will be opening soon for our January webinars. The first one will be on Am I Safe with You? Exploring the underlying question of communication in crisis moments. And this will be January 9th. This is our donation-focused webinar. And then our first transplant webinar for 2018 will be on the topic of health literacy. So for today's webinar, we are offering 1 CEP-C credit and also 1.2 nursing contact hours. That's courtesy of Iowa Donor Network, and we thank them for the ongoing sponsorship for the nursing contact hours. So everybody who's listening today is entitled to receive continuing education credits. So if you are listening in a group, whoever registered for your group or received the webinar link will also be the person who receives the evaluation email. So please make sure to get that evaluation email from them. If you're the one coordinating such a group, please make sure to pass on the evaluation email to everyone in your group so that everyone who completes the evaluation can receive continuing education credits. As a reminder, for CEP-Cs, you do have 30 calendar days, but for nursing, you only have 14 calendar days to complete your evaluation. So please make sure to request those continuing education credits within that time frame. So at this point in time, I'd like to introduce our moderator for today. Christine Palms is a member of our Transplant webinar faculty, and she did a great job in organizing, identifying our speaker for today and organizing everything. Christine is the Director of Transplant Services at Lourdes Health System in New Jersey, and so I'm going to turn it to Christine to introduce our speaker.
Thank you. It is my pleasure to introduce Dr. Nicole Ali, who is currently an assistant professor of medicine at the New York University School of Medicine, and she's also a transplant nephrologist at the NYU Transplant Institute. Following completion of her undergraduate degree at Brown University, she joined AmeriCorps program for Teach for America as an 8th grade science and math teacher. She earned her medical degree from the State University of New York, Stony Brook campus. She is board certified in internal medicine and nephrology. She is an AST/ASN certified transplant nephrologist trained at Columbia University in New York. She has held positions as the Chief of Transplantation at Hackensack University Medical Center for kidney and pancreas transplant, as well as the Medical Director of the Kidney Program at North Shore University Hospital. She has extensive experience working with programs who experience outcome issues, including working her way through system improvement agreements and restructuring transplant quality programs. She has published many articles in peer-reviewed journals and presents lectures locally and internationally. Along with her interest in transplantation and quality, she continues to work on preventative medicine strategies, especially focusing on diabetes, hypertension, and kidney disease. Please join me in welcoming Dr. Nicole Ali.
Thank you, Christine. Good afternoon, everyone. First, I'll apologize. I caught my cold from my little kids, and so I apologize if I start coughing in the middle of this. So just a little background. The idea behind this talk came about because I think there are a lot of things that we do in transplantation that are focused on outcomes, and we have many tools available to us. So what we'd like to do today is share some of the tricks of the trade, so to speak, that we've learned along the way. So I have no disclosures. Our objectives are really going to be focused around reviewing the SRTR models and being able to utilize the tools that are available in order to be able to help a transplant center navigate the arena of transplant outcomes. So when we talk about transplant outcomes, there are really a lot of invested partners. First, our patients. SRTR's website is all publicly available. It is much more user-friendly now than it was when I started. And patients really are able to navigate it to be an informed consumer in healthcare. They're able to look up various transplant centers in their area, what their program rates look like, what their survival rates and outcomes look like, what their wait list looks like. So there's really a lot of information at our patients' fingertips, and that's really important that we engage with them on how to use the information that's out there. Of course, our two main regulatory bodies, UNOS and CMS, are very interested in programs' transplant outcomes, and payers utilize this information as well, especially when it comes to centers of excellence and where they funnel patients. And then finally, on the transplant center front, we're all interested in our outcomes because we want to be excellent at what we do. As we innovate and we grow in transplantation, it's important that we do it well. So we're going to spend quite a bit of time talking about SRTR and going through the tools, and I hope that you'll all be able to leave here today with some idea of how you can take the information and the tools at hand and really apply them to your program to help you, pave a way for how to be even better than you already are. So just a little bit of background. The Scientific Registry for Transplant Recipients, SRTR, is operated by the Chronic Disease Research Group, which is a division of the Minneapolis Medical Research Foundation. SRTR basically is responsible for providing statistical and analytic support to the Organ Procurement and Transplantation Network, as well as HHS and CMS. And much of the data and output that they provide to these organizations goes towards policy formulation, evaluation of the policies, system performance metrics, economic analyses, and then ultimately to our patients. Just a quick snapshot. If you remember nothing, remember these dates. So this is just a snapshot of what's on SRTR's website right now, pertinent to transplant programs. These are the upcoming dates that you would need to be cognizant of as information is released. So as you all know, SRTR releases program-specific reports twice a year, generally around January and around July, publicly on the SRTR website. Prior to that release, programs are given an opportunity to review their data, submit corrections to OPTN, and then what's coming up now on December 15th, programs will get their private PSR release on the Secure SRTR website. And we'll take a look towards the end of the presentation of what some of the things that you can get through the SRTR Secure website look like. January 5th, the PSR will be publicly released on srtr.org. And then you do have about a 6 to 7 week period of time where you can submit comments which could accompany your public reports. So these PSR reports, they're really quite extensive, very lengthy, and they really give a tremendous amount of information about a program. So you can really utilize this report to take a deep look at what your program is doing and how you can really grow from there. The source of the information that goes into these analyses comes from a number of places. OPTN submits all their data, so everything that is put into UNET goes into SRTR's database. CMS files, the death master file, and then a number of other databases submit information. So the scope of the information in SRTR's database is really quite wide. And that would explain why sometimes you get a 50 or 65 or maybe even longer page report, which is meant to be much easier and more graphically pleasing, but it can be quite daunting to look at that. So when I look at it, there are a couple of things that I want to look at, on my first read. One is, what's my waitlist mortality looking? What's my time to transplant looking like? My transplant rate? And then ultimately the one I look at first but listed last is, what's my survival following transplant look like? So like I said, these reports are published every 6 months. Two key things, patient survival and graft survival, are the two things that a lot of us gravitate to quickly. The SRTR report does show you broken down by organ type and at different intervals, 1 month, 1 year, and 3-year post-transplant outcomes for all of your organ types. For graft failure and patient deaths, SRTR looks at this in a rolling 2.5-year cohort. So it's always retrospective and always about 1 year behind where the publication date is. Each of the different metrics in the report, however, has a different time period. So when you look at patient and graft survival, for the report that's currently out, it's a 2.5-year period encompassing January 2014 to June 2016, and that's what's currently published. The time period currently in process, which is due to come out in December and then publicly in January, drops off the last 6-month period and adds on another 6-month period. So you're always using a 2.5-year cohort, but it's a rolling cohort. The publication to be released mid-2018 would utilize this 2.5-year cohort, January 2015 to June 2017. It's important to have these in mind when you're looking at your center's data real time, because SRTR is great for giving you risk-adjusted data on a every 6-month basis. However, you're always going to be looking at data that's about a year old. As a transplant center, you want to also look at where are you heading and what's your data look like now. So you need to be able to keep track of what these cohorts will look like and when these cohorts will hit. This is a snapshot. You can find this on srtr.org. This is just a quick snapshot of all of the different cohort periods for the different metrics which are reported in the big report. So here we see for graft survival 1 year and graft survival 3 years, you have different cohorts, but they're always a 2.5-year rolling cohort. And I encourage you to take a closer look at that. This is just a quick snapshot, because when I first looked at one of these reports, straight out of fellowship and working my way through learning a lot about programs and SIAs, the report was just unmanageable. And for someone who's new at looking at it, I really try to highlight just a couple of areas where you start off. So the report's basically broken into 4 parts. The first part is just your first page. It's a quick snapshot of what your data looks like, waitlist data, outcomes data, and it's a very quick place to take a look at, some of the things I mentioned. Section B really goes into a deep look at your waitlist. What are your transplant rates? What's your waitlist mortality rates? What are the demographics of your waitlist? The time from transplant from waitlist to transplant for candidates is something that patients often look at, so you want to be familiar with. And they also have a section that looks at your offer acceptance practices, and that's something that you may be able to look at in order to try to see where you may be able to optimize transplants at your center. Section C focuses on the post-transplant patients. So it gives you a lot of information about what you have put into UNET on the demographics of your recipients, both deceased donor and living donor recipients. And what we all look at is the graft survival section. So we've got patient survival, graft survival, and a very detailed section on what those numbers look like. And the last section is your living donor information. So now, taking a closer look at exactly what we're talking about when we look at those survivals. So for CMS and MPSC, which is OPTN, there are different flagging criteria. CMS still has flagging criteria based on the observed and expected numbers of deaths or graft survival. So a program is considered out of compliance when they meet all three of these thresholds. Their observed events is more than the expected by 3. The ratio of the observed to expected is more than 1.85, and that has increased from 1.5 a few years ago. And the p-value is significant at less than 0.05. A program has to meet all three of these flagging criteria, and then they would be considered out of compliance. For CMS, if a program is out of compliance on 2 consecutive reports, then they would be at risk for being cited for noncompliance on outcomes. Programs that currently have data which shows that they have improved outcomes may not be cited at a condition level if their current outcomes are good compared to the 2 that are on the SRTR reports. And this is where I emphasize, while the SRTR reports are great and have a lot of great information, it's important as a center to know what's your real-time outcome looking like. Because if you are flagging on a report, you want to be able to say, am I good to continue to flag? So I need to prepare for different things. Or is my current data now in a stable position so be able to justify what got you to a better standing? The OPTN, maybe about 2 years ago, changed from the previous criteria to a Bayesian model for flagging. So in order to support that model, SRTR calculates a hazard ratio. Hazard ratio is a measure of a program's outcomes relative to the expected outcome. So a hazard ratio of 1 means the program is performing exactly as they would be expected to perform. A hazard ratio less than 1 means that the program's survival rates are better than expected, and a hazard ratio greater than 1 means that the program rates are worse than expected. So when you look at the Bayesian model, in the report, they show you your hazard ratios, and I'll show you some examples of that in charts. But on your secure release, you get an Excel file, and the Excel file shows you the probabilities that your hazard ratios are exceeding certain thresholds. So in this model, rather than having to flag on 3 different things, they provide you with probabilities. So if the probability that your hazard ratio is greater than 1.2 is more than 75%, then you would flag for MPSC. If the probability that your hazard ratio is greater than 2.5% is greater than 10%, then you would flag for MPSC. Small volume programs, which are programs that do fewer than 10 transplants in a 2.5-year period, they're flagged if at least 1 graft failure or death occurs. And the shift to the Bayesian model was in part driven by the concern that the previous model was flagging many programs that were small and missing other underperforming programs. So what has been shown is the shift to a Bayesian model does flag less small volume programs and does flag more of the middle-sized programs, flags about the same number of what's considered large programs. So currently, you do have to look at 2 different flagging criteria, both of which are available on the same secure file. So now when we look at the actual report, this is a snapshot of what the report PDF would look like. So this is an example of looking at an adult program's 1-year survival for graft. It gives you the time period, so this is looking at January 2014 to June 2016, that 2.5-year period. And in this, it notes deaths and retransplants are considered graft failures, and that's important to note when we talk about the difference between the cohorts for graft survival versus the cohorts for patient survival. So this is the center's data, and this is national. It shows you the number of transplants in that cohort, the unadjusted probability of surviving with a functioning graft at 1 year, 95.81%, compared to the national benchmark, which is 85%. And then SRTR does adjust for the risks of the patients in that cohort, and they arrive at an adjusted patient graft survival, of 95.6%. So that is pretty close to the expected. They also give you the raw numbers. So in this particular program, of the 677 grafts, 27 of those had failed within the first year. And based on the risks of this particular cohort, this program would have been expected to have 27.75 grafts fail. So that tells you that this program is performing exactly as they would be expected, so their hazard ratio is very close to 1. And this graphic here you would get for 1 year, 1 month, 1 year, and 3 year graft survivals and patient survivals for adult and pediatric programs, depending on what programs your institution houses. This is a picture of the hazard ratio. So for that program we just spoke about, which has a hazard ratio of about 1, you would see underneath that table this section of pictures. So you see a graphic description of the estimated hazard ratio and where this program falls, almost exactly at 1, demonstrated by this arrow. And then they also show on a display of the other programs in blue where this program would fall. Now, if there is a program that was performing not as well, you can see here their graphic description, the bell-shaped curve is shifted a bit, so the hazard ratio lies here at 1.37, and their blue indicator for this particular program shows that they're a bit above 1, which they demonstrate clearly with a slightly worse. This does not mean that this program is flagging. It's simply demonstrating where their hazard ratio is. In order to know whether your program is in jeopardy of flagging, you would have to see that on your secure file in the probabilities of your hazard ratio greater than 1.2 or 2.5 section, and I'll show you that towards the end. So we mentioned briefly that there is a difference between your graft survival cohort and your patient survival cohort. So when you look at your file, you'll notice that the total cohorts in the same period of 2.5 years, your total number of grafts is different typically than your total number of patients. And that's because the graft survival cohort includes all grafts implanted in that 2.5 year period, regardless of whether the person had a previous transplant. In the patient survival cohort, however, only patients who are getting their first-time transplant are included. So if a patient had a previous liver transplant and is now getting a kidney transplant, they would not be included in the patient survival cohort, but they would be included in the kidney graft survival cohort. That's where you can see some discrepancies. So one of the things you also want to do internally when you try to project your outcomes is to keep track of which patients are retransplants or which patients are multi-organs, so that you know to include them in your graft survival cohort but not in your patient survival cohort. Now, in terms of when SRTR receives this data from the OPTN via what we have put into UNet, sometimes there's very similar data inputted into different forms. So for example, the TCR forms and the TRR forms have some similar fields. In order to know exactly which form the data is coming from, SRTR does give you that information. On their website, if you go to the section under the Risk Adjustment Model and click on the Model Elements tab, that provides you with a complete list for every organ of the element and which form in UNET that information is being pulled from. So you'll see here for candidate, whether they have diabetes at listing, they pull that from the TCR form. Donor information is pulled from the donor form, or whether a patient had a previous solid organ transplant is pulled from the TRR form. So it's important to know where your information is being pulled from, and it's very important to review the accuracy and the completeness of the information that you put into UNET, because ultimately that's what will be transmitted over to SRTR. Now, taking a look at the risk adjustment model. So remember we talked about you have your outcomes, your observed number of events, and then that's compared to the expected number of events. Your expected number of events is determined by SRTR based on this risk adjustment model. So for every organ, the risk adjustment model is different. This risk adjustment model is revised every 6 months based on new data. So if you go onto the SRTR website, what you will currently find is the July 2017 model. You can also look up the previous model using this drop-down. So if you go onto srtr.org and you go to Tool, Reports and Tools, you can find for transplant programs the risk adjustment models. There are a number of preview beta tested models as well for the transplant programs. I encourage you to explore this area. Once you click on the transplant program, it brings you to this screen where you choose a release date. So the currently most recent release date was from July 2017. So if you click on that, it will bring you over to this panel. And here you are able to pull up the risk model for any organ transplant based on donor type and age group, and look at the actual outcome that you want. So for example, if we look at the kidney deceased donor adult transplants, and we want to look at some of the elements which go into the risk adjustment model for patient survival, once we click all of these things and we're looking at 1-year survival, you'll come across a bunch of tabs here, one of which will have elements plots. I find this is the easiest way to look at the various elements that went into the model to figure out which are the things which have weighting and which are the things that we need to hone in terms of accuracy. So in this example, if we look at the candidate's diabetes status at listing, we see that people who have missing data or do not have diabetes have a hazard ratio less than 1. People who have type 1 diabetes have a hazard ratio of 1. Type 2 diabetes has a hazard ratio of about 1.3 almost. And if we put in an unknown type, hazard ratio is 1. So the way you interpret this is that patients who have or any category which has a higher hazard ratio has a more heavy weighting in terms of risk. So if we look at our data and we see a lot of our patients have missing, you want to take a look at your source to see why are you missing these data elements, because you could potentially be missing some information which would factor into the weighting of the patients that you transplant at your center. So what we do here at our center is we review this model every 6 months for each of the organs. And this is a very quick snapshot of one of the sheets that we put together, just so that as a program we know what things we need to be sure that we are looking at accurately. You always want to ask yourself, is your data accurate? Is it complete? And in order to do that, you need to look at who's entering your data, where's the information that they're entering into UNET coming from, and how can you make that capture of information more efficient. As we all have electronic records, we know there's so many different places to put information. we want to make sure that our staff have the ability to extract that information in an efficient and accurate manner. So this is the way that we display it. You don't have to do this, but you should at least look at the model and find a way to categorize it. For us, we categorize it by graft survival, deceased donors versus living donors, and patient survival, deceased donor organs versus living donor organs. This is for one of the models we looked at, and this is the 1-year points in, I believe, kidney. Now, in order to really be engaged with where your data is heading, you really need to make sure you have access to your secure SRTR website, because that provides you information on your PSR timelines. It provides you with updates on tools and reports that are available. You can access your QSUM reports through the secure SRTR website. And you also access your draft secure reports. So the draft reports are the reports that came out early in October, and they also provide with those reports data integrity reports, which are Excel files, and that allows you to check for data accuracy and completeness. The Excel files at first can be a little daunting, but if you take the time to read through the instructions and read through the tabs, you'll find that they're actually pretty easy to navigate, and it allows you to very quickly take a look at what information you maybe did not put in. It also highlights for you any of the information that was put in, which is sort of an outlier of the norm or the expected, and it provides you a way to review all of your information which was put into UNET in one file rather than having to go into individual patients in UNET. The file does come over blinded, and if you need it unblinded, you can request that through SRTR. But for the most part, you could probably also figure it out yourself, because they have information like transplant date, and it's broken up by living donors and deceased donors, so you can pretty much figure it out easily. Once you review your data integrity report and you make any corrections to inaccurate data, those corrections are made via UNET, and then that information is fed back to SRTR. The next important date becomes the date at which SRTR gives you a secure private preview of your data. And that private preview includes an Excel file which shows you the Bayesian model and the CMS flagging criteria, in addition to your detailed data on that cohort which is currently in play. So this is an example of what the front of that Excel file looks like. So in this secure release file, your expected survival worksheet, it does give you a snapshot with the Bayesian model. It gives you, for the cohort at play, this one being patient survival, the number of transplants in that cohort, what your observed number of events was, your expected number of events, and it gives you the MPSC flagging criteria and the CMS flagging criteria. So while the SRTR public report gives you information, and it does say, as expected, lower than expected, or greater than expected, this really gives you, the secure internal file really gives you the ability to project where you're headed once you get comfortable utilizing it. So again, the Bayesian model provides this bell-shaped curve, and it gives you an indication of where on the curve your program's performance is most likely to fall. If you shift further over to the left, it means that your outcomes are good. Further shifts on the bell curve to the right are consistent with poorer outcomes. So in this particular case, the probability that this program hazard ratio would be greater than 1.2 is 21%. In order to flag for MPSC, there would have to be a 75% probability that the hazard ratio would be greater than 1.2. So for this scenario, this program is in a pretty stable situation in terms of outcomes. The probability that the hazard ratio is greater than 2.5 is 0.4%. The MPSC flagging criteria is at 10%. So again, pretty far from 10%, a very comfortable position to be in. It does tell you very clearly, has this program flagged by standard criteria? False, so they are not flagging, and they are not a small volume program. On the same page, it gives you the CMS criteria. So the observed minus expected is not greater than 3. The ratio is not greater than 1.85, and the p-value is not significant. So it tells you that this program will not flag based on CMS criteria. So one of the things that I encourage programs to do is to really utilize these SRTR files to be able to predict where your program lies. And in transplantation, we can never be sure what tomorrow brings. We hope that we select patients who are going to do well, but there are certainly unforeseen events that happen. So what I also encourage programs to do is look at the what ifs. So this is an example here of a chart that I've used in a couple of different places to just have a really quick snapshot of where we are now and where we may be next year, especially because the SRTR data leaves you a year behind. And while the QSUM reports do show you where you are real time, it doesn't give you the same picture. So it does show you if you're heading in the wrong direction, but it doesn't show you what we typically look at as the flagging criteria. So here I have the different transplant periods. So the period from January 2014 to June 2016, this is the currently published period. That's the SRTR report date. This is looking at patient survival. So in this cohort, say there's 78 patients. Expected would be 2.5 deaths, and that's gotten from the SRTR files. It's already published. There were 2 actual deaths, so these are the observed CMS flagging criteria, and they're all in green because they don't flag. For the upcoming report, December 2017, and forgive me if the numbers don't exactly add up because I didn't make these up. So for December 2017, that cohort drops off the first half of 2014, adds on the second half of 2016, so it's still a 2.5-year cohort. Program volumes went up nicely to 125 transplants in that 2.5-year period. So expected to have about 4 deaths, observed 3 deaths. So that still leaves the numbers in a pretty good shape. As you go on, what I like to look at is for the upcoming cohorts, what if? So right now, you're pretty close to the end of this cohort because you're almost 1 year out. You've got 1 more month before you're before all the patients transplanted in that cohort have definitely met the 1-year mark. So you're kind of secure that these numbers may be pretty stable. Where you're not secure is what happens in the periods of time where you do have patients who still have at-risk days or months. So if nothing else happens, so 0 is if no other events were to happen, then you take a look at where you're at. If you were to have more events, then I change the numbers here in the observed to try to get to the point where I see how many events would lead us to a threshold which would not be good. So assuming that the number of expected deaths would stay the same, and they shouldn't because as your volume goes up, this should go up, assuming your risk adjustment is appropriate. As you plug numbers in here, you'll see the ratios do start to trickle up as we have more events, and your expected starts to trickle up. The p-values are not easy to predict, so what I put is if these 2 things are flagging, it's quite likely that you're going to flag at your p-value. There are many different ways of looking at projecting your outcomes. This is just one quick example. But for each of your programs, you should take a look at how can we actually look at our real-time data. The SRTR Secure worksheet does also give you the ability to do this by changing the numbers here, and it will give you a change here. So if we were to use the same sheet, and I changed from observed of 2 to observed of 6 events, then you see the probability of the program having a hazard ratio greater than 1.2 changes from 21 to 81. So this program would end up flagging based on the criteria here. So that's just another way that you can try to manipulate the SRTR secure file, which already has all of the formulas built in, to take a quick look. You're never going to be able to get perfectly the exact numbers of SRTR because that risk adjustment model changes every 6 months. But it does give you a pretty good idea of where you stand, which should help with being able to figure out, in terms of increasing volume, increasing risk, expanding type of donors that you take, where you're comfortable innovating in transplant. So with that, I hope that I have given you all some information that you can use at your program, and I'll be happy to take any questions.
Thank you so much, Dr. Ali, for a wonderful, very educational presentation. I know I learned a lot. So for all of those who are participating today, if you have questions for Dr. Ali, all you need to do is click on that bottom left-hand corner where you see that little chat icon. Type in your question, and then Christine will moderate those questions for you. While we have the Q&A going on, I'm going to have this poll up. And for those of you listening in a group, if you can complete the poll as to how many people are in your group, that would be very helpful. So I'll turn it back to Christine to start moderating our questions.
Thank you. Dr. Ali, my first question is, you talked about the importance of capturing accurate data on the forms as they relate to the different elements. So either what is your recommendation or what process do you currently use now for capturing that information for your TCR and TRR forms? Who completes it?
Sorry, we're right off the FDR. So the question is, if I heard it correctly, what's our process for accurately capturing the information on the TCR, TRR forms?
Yes.
Okay. That's always been a challenge. I've done various things over the years. I've worked in programs where our clinical staff, our coordinators, inputted information into UNET. I've worked in programs where I've got a data team that's doing it. I've worked in programs where we've got, coordinator assistants who are doing it who aren't clinical. So I think it's always a challenge to figure out exactly how do you get the right information into the right place. One of the things, I think each program has to sort of look at their process and figure out what works for them. In one of my programs, we created just a quick worksheet of the items which needed to be entered for the TCR form. And at our listing meeting, as we presented the patient's history, one of the physicians would actually circle off, like, this person has diabetes, cancer, vascular disease, whatever came up in the history. I've had programs where we did that, but really did it outside of the listing meeting because the listing meetings can get very busy with discussions. So the team members broke the categories into, the financial coordinator handled the insurance questions that are on there. The social worker handled the education questions and some of those points, and then the coordinator handled the clinical part, and then they just shared the document. Currently, we have a data team where we try to extract the information from our documentation in Epic, which we're still, working on how to make that really streamlined, but unfortunate to have a great data team that works really hard on trying to get the information out of the chart. And if they can't find something, then they come to either the coordinators or the physicians and say, look, I can't find this patient's functional status. You saw the patient, you documented, is this accurate? It's always a challenge.
Thank you. The next question, UNOS Data Service is providing a data integrity file with patients' information labeled in the future. Do you think that this will be helpful as far as assessing the data and also, I guess, projecting, a more accurate outcome for patient and graft survival?
I think that the SRTR files are very heavily UNOS data, and so I think that partnership between SRTR and UNOS is going to be a very productive one. I think definitely having the patient information and directly from there would be useful. But so far, I think, from when I first started using the SRTR Excel files to now, they've become a lot more user-friendly. And I think that there's certainly something that every program can take a look at. You don't have to have as much trepidation about messing anything up in the file. And what I always do is I save an original copy, and then any changes I make go on a draft copy. That way you've always got your baseline data without messing with the formulas, et cetera. But I do find it to be pretty useful.
Christine, did you have any further questions for Dr. Ali?
My only question, Dr. Ali, when you are working through the outcomes in patient and graft survival, as far as it seems like it's very robust and comprehensive, what key team members do you have working with you, working on the outcomes? And I guess it's always, like you stated, a challenge, getting everyone excited about the quality aspect. Who's working on your team, and how do you, I guess, get everyone encouraged to or buy into the process and how important it is?
So I think the first part is understanding. So I think that the SRTR reports are so extensive that it can be very intimidating. And so for us, I think, here at NYU, we have a really great collaborative partnership with our surgical team, our medicine nephrology team, and our quality data team. So about every month we meet to review all of our post-transplant patients, and really it's a combination of an outcomes and a clinical meeting where we're able to take a look at what our outcomes look like. We're also take a look at individual patients who maybe need a little extra attention, maybe need to be seen in clinic more often, and by combining the charts and the numbers and the percentages with the clinical data, the patient data, day-to-day, that really, I think, engages the clinical team in why this is important. We've really been fortunate to have a team that really wants to understand the models, and being able to use some of the things on the SRTR website where we don't always all have time to go on the website and click the different parts of the model, but a couple of us will do that and then be able to demonstrate out to the liver transplant team or to the kidney team, hey, did you realize that the type of diabetes matters because look at the risk adjustment model and you see that type 2 diabetes is more heavily weighted than type 1. So if in your history you're only just writing diabetes, the data team cannot discern type 1 or type 2. They put type unknown. And type unknown is, a hazard ratio of 1, whereas a type 2 is a hazard ratio of 1.3. And so being able to take just a few pertinent clinical points and demonstrating the impact it has, I think has really helped engage our clinical team in improving their documentation. So that's what I would suggest is if you have a couple of people at your program who are really into the data and the statistics and really love this website, if they can get together and then figure out how they can partner with the clinical team to say and demonstrate the importance of why this has an impact down the road. Because at the end of the day, we all love to transplant, we all want to innovate, but we do also have to do it within parameters which we're not always in agreement with, but it is the reality. So there's a way to do it, I think, and partner with the two halves and make it a really productive relationship.
Thank you. the next question, in addition to missing data, do you also assess accuracy of the data for the highest rated coefficients?
Yes, we do. So we use the SRTR file. On the from second or third tab on, the files break up your information based on deceased donor, patient survival, living donor, patient survival, then deceased donor, graft survival, and deceased donor, living donor, graft survival. So you basically have, for the 1-year cohort, you're looking at 4 different tabs, and then for the 3-year cohort, you're looking at 4 different tabs. So some of this is duplicative. So what we do is we take our data, we get rid of the duplicative information, and then we do look at, for things that are heavily weighted, what is the accuracy. And in order to do that, many of them are clinical items, so we end up partnering with a physician or a coordinator to do those chart reviews. For us with Epic, it's pretty easy to do searches for keywords. But even in my previous programs where we didn't have that, it was important to do because oftentimes people document things differently, and it's not always in a very readily accessible place. It's not realistic, I think, to do it for every coefficient, but you do want to do it for some of the more highly rated coefficients if that's something you have the people power to do. Otherwise, moving forward, you do it, as you list patients.
All right. Well, thank you so much, Dr. Ali. Christine, did you have any further questions? Or?
No, no more questions at this time.
Okay, great. Dr. Ali, thank you so much for a fantastic presentation. I think it was extremely educational. I actually understood it, and I don't look at the data all the time, so hopefully everybody else found it beneficial as well. And I want to thank all of the participants for being part of today's webinar. Thank you, Christine, for moderating it. And seeing that this is our last transplant webinar for the year, I want to wish everybody a very happy holidays. Thank you for those of you who are working to let others have the day off. And we wish you all a wonderful rest of the year.